Welcome to the deep dive. Today, we're tackling a topic many of you have actually asked about, antipsychotic drugs.
Yeah,
We've got some really interesting material here that helps us understand how these medications work, especially when someone's experiencing what our sources call a pretty significant disconnect from reality.
right. That's a good way to put it.
We're talking about things like hallucinations, seeing or hearing things that aren't there, and delusions, these really strong fixed beliefs that just don't line up with reality.
Exactly.
Hmm.
And our mission here really is to pull out the key insights from these documents on antipsychotics. We want to give you a clear picture of what they do, how they work, without burying you in like super technical jargon.
Right. Kind of the essential need to know.
Yeah, think of it as your quick guide to understanding a really important part of treating certain mental health conditions.
Okay. And the info we're digging into today, it comes directly from a document focused specifically on these antipsychotic drugs. So to get us started, maybe let's just outline what psychosis actually involves.
Sure. At its core, it's a state where someone's grasp on, well, what's real is significantly altered.
Okay.
And schizophrenia is probably the best-known condition where these antipsychotics are really central to treatment.
Right.
And it's important to get that schizophrenia isn't just one thing. It shows up in different ways, often grouped into what we call positive and negative symptoms.
Okay, positive and negative. Let's break those down. Our source material seems to lay them out pretty clearly. Positive symptoms. These are things like agitation.
Yeah, agitation, delusions, those really firm false beliefs we mentioned, disorganized speech, kind of jumbled thinking.
Hallucinations.
Hallucinations, definitely. Hearing voices, seeing things, even insomnia, trouble sleeping can be part of it.
And the document says these are often linked to, like, too much activity in a certain brain pathway, the mesolimbic pathway.
Exactly, that mesolimbic pathway. Think of it like the brain's reward and motivation circuit kind of going into overdrive.
Ah, okay.
And these positive symptoms, they're usually what's most prominent during, an acute episode.
Got it. So those are the positive ones, things added to experience, in a way. What about the negative symptoms?
Right, the negative ones are more about something being missing. So things like apathy, what's called affective flattening.
Affective flattening.
Yeah, it's like a reduced outward show of emotion. Someone might watch something really sad or funny, but have like a blank expression.
Okay, I see.
Also, lack of motivation,
Hmm.
not finding pleasure in things. That's called anhedonia.
Anhedonia, right?
Poverty of speech, just not talking much, and social isolation, pulling away from others.
And these are linked to a different brain area, the mesocortical pathway, the source says. And maybe insufficient activity there.
That's the idea. Insufficient activity in the mesocortical pathway. And these negative symptoms, they're often, frankly, harder to treat.
Hmm.
They can persist even when the positive symptoms get better. And unfortunately, they're often linked to a poorer long-term prognosis.
So it's kind of a double whammy, overactivity causing some problems, underactivity causing others.
You got it. And this difference is actually key to understanding the shift from older to newer antipsychotics later on. The older ones were maybe better at the positive symptoms, while the newer ones try to address both.
Interesting. Okay, so how did the drugs actually tackle this? This brings us to the dopamine hypothesis, right?
Absolutely. The dopamine hypothesis has been, well, really central to understanding antipsychotics for a long time.
And the evidence for it.
It's pretty compelling. First, as our source points out, most antipsychotics block dopamine D2 receptors. And there's a pretty clear correlation. The better a drug blocks these D2 receptors, generally, the more effective it is clinically, especially for those positive symptoms.
So more blocking, more effect. Seems straightforward enough.
For the typicals, yes, it's a strong link.
And the second bit of evidence.
The second key point is that drugs we know increase dopamine activity, things like amphetamines, for instance, can actually cause psychotic symptoms in some people, or make existing ones worse.
Right, that makes sense. If too much dopamine is involved in psychosis, then drugs that boost dopamine could trigger it.
Precisely. And the document also briefly mentions extrapyramidal side effects, those movement problems, and raised prolactin levels. These are also linked to dopamine receptor blocking in other brain areas, which kind of hints at how complex this system is. We'll definitely get more into side effects later.
Okay, so the core idea is dopamine activity seems dysregulated, particularly maybe too high in some areas for positive symptoms, and antipsychotics work, at least partly, by blocking dopamine receptors. How exactly do they do that blocking?
So generally they work by competitive antagonism. They basically get in the way. They bind to dopamine receptors usually the D2 type on the postsynaptic neuron, the one receiving the signal.
Okay.
And they also interact with serotonin receptors, often presynaptic ones, the 5-HT2A type being important. They compete with the natural neurotransmitters for those spots.
And this is where the big split comes in, typical versus atypical antipsychotics, based on which receptors they prefer.
Exactly, that's a key distinction. The older or typical antipsychotics generally have an equal or even stronger affinity for those dopamine D2 receptors compared to the serotonin 5-HT2A receptors.
Right.
And like we said, for typicals, there's that strong correlation.
Yeah.
The tighter they bind to D2, the more clinically potent they tend to be at reducing positive symptoms because they're blocking dopamine in that overactive mesolimbic pathway.
But, and this is a big but, isn't it? That same strong D2 blocking happens elsewhere too, like in the basal ganglia, which controls movement.
That's the major downside. Blocking D2 receptors in the nigrostriatal pathway, which involves the basal ganglia, is what leads to those Parkinson's-like side effects, the extrapyramidal symptoms, or EPS.
Okay, so the typicals are a bit of a blunt instrument in that sense.
You could say that. Now, the atypical antipsychotics, the newer ones, generally have a different profile. They tend to bind more strongly to those serotonin 5-HT2A receptors than they do to the dopamine D2 receptors.
Okay, so they prioritize serotonin blocking over dopamine blocking?
Or at least have a more balanced action, or weaker D2 binding. And the theory is, by blocking those 5-HT2A receptors, particularly in the mesocortical pathway, the one linked to negative symptoms,
Right, the underactive one.
they might actually increase dopamine release in that specific area.
Whoa, okay. So blocking serotonin in one spot might boost dopamine somewhere else.
That's the hypothesis. And it could explain why atypicals often seem better at helping with those negative symptoms, and also why they tend to cause fewer of those EPS movement problems, because their D2 blockade is maybe less intense or more transient.
That's really fascinating, a much more nuanced approach. Now, our source also mentioned something important. It can take, what, about 6 weeks for the full effects to show? And we don't totally understand exactly how it all works long term.
That's absolutely right. The immediate receptor blocking happens quickly, but the full therapeutic benefits often take weeks to develop. It suggests there are slower, adaptive changes happening in the brain.
Like the brain adjusting.
Exactly. And the precise downstream effects, well, they're still being figured out. The document does describe sort of 3 phases of change in dopamine activity after starting these drugs.
Okay, what are those?
So initially, the brain often responds by actually increasing dopamine synthesis and release. It's like a compensatory reaction to the receptors being blocked.
Like pushing back against the drug?
Sort of, yeah. But then, over time, with that continued D2 blockade, dopamine release tends to decrease. They call it depolarization blockade.
Depolarization blockade.
Yeah, essentially the dopamine neurons reduce their firing rate. And this reduction, especially in the mesolimbic pathway, is thought to be crucial for the improvement in positive symptoms.
But that same reduction in the movement pathway causes the EPS.
Precisely. And then there's a third, longer-term change.
Okay.
With prolonged reduction in dopamine stimulation, the D2 receptors themselves can actually increase in number and become more sensitive. It's called upregulation or supersensitivity.
So the brain becomes extra sensitive to any dopamine that is around.
Exactly. It's like turning up the volume to hear a faint signal. And this dopamine receptor supersensitivity is believed to be a major factor in causing tardive dyskinesia.
Ah, that delayed movement disorder.
The very one. It can show up much later and, worryingly, can sometimes be permanent.
Yeah.
It really underscores the double-edged sword nature of long-term dopamine blockade.
Wow. That really highlights the incredible complexity here. Okay, let's shift gears slightly and dive deeper into the side effects, starting with those older, typical antipsychotics. The source breaks them down.
Yes, because typicals often hit multiple types of receptors, not just dopamine. They come with a range of potential side effects. One group is autonomic nervous system effects, often worse with the lower potency typicals.
Autonomic, like automatic body functions.
Right. So blocking muscarinic acetylcholine receptors can cause things like blurred vision, dry mouth, constipation, difficulty urinating. Pretty uncomfortable stuff.
Yeah, definitely. And blocking alpha-1 receptors, what does that do?
Blocking alpha-1 adrenergic receptors can lead to dizziness, especially when standing up. That's orthostatic hypotension and sometimes a faster heart rate as the body tries to compensate, called reflex tachycardia.
Okay.
Then there's histamine H1 receptor blockade. That's often linked to drowsiness, sedation, and sometimes significant weight gain.
So sleepiness and weight gain, too. It's quite a list already.
It is. And then, of course, there are the extrapyramidal symptoms, the EPS, which you mentioned. These are generally more common with the high-potency typicals, the ones that block D2 very strongly.
And remind us what EPS includes.
So there's akathisia, this awful inner restlessness, feeling like you constantly need to move.
Oh.
There's pseudo-Parkinsonism, which looks like Parkinson's disease with tremor, muscle stiffness, slow movement. And dystonias, these are sustained, often painful muscle spasms or contractions, causing twisting movements or abnormal postures.
Those sound genuinely distressing.
They can be incredibly disturbing for patients, absolutely.
The source also mentions increased prolactin levels.
Yes. Blocking D2 receptors in the pathway that controls prolactin release from the pituitary gland, the tuberoinfundibular pathway, causes prolactin levels in the blood to go up.
And the consequences of that?
In men, it can sometimes cause breast enlargement, called gynecomastia. In women, it can lead to menstrual irregularities or even milk production when not pregnant.
Okay. And were there specific side effects tied to certain older drugs mentioned?
Yeah, a couple were highlighted. Chlorpromazine was linked to potential liver toxicity or hepatotoxicity, sometimes causing jaundice. And thiordazine had risks of pigment retinopathy, an eye problem, and cardiac toxicity. These specific risks are part of why some of these older drugs are used less frequently now.
Right, understandable. And lastly, for the typicals, the source mentions something called neuroleptic malignant syndrome, NMS. You said that sounds serious.
It's very serious. NMS is rare, thankfully, but it's a potentially fatal reaction, usually linked to higher doses. It's a medical emergency.
What are the signs?
It involves a cluster of symptoms. Really high fever, extreme muscle rigidity, like lead pipe, rigid sweating, confusion, unstable blood pressure and heart rate, potential cardiovascular collapse. Lab tests often show very high levels of CK, creatine kinase, from muscle breakdown.
Wow. And the treatment?
Immediate stop of the antipsychotic, obviously. Intensive supportive care and specific medications like bromocriptine, which stimulates dopamine receptors, and dantrolene, a muscle relaxant, are used to try and reverse it.
That is really sobering. Okay, let's focus a bit more on those extrapyramidal symptoms, the EPS. The source differentiates between acute EPS and tardive dyskinesia.
Yes, the acute EPS, the akathisia, pseudoparkinsonism, dystonia we talked about, tend to appear relatively early after starting the drug or after dose increase.
And can those be managed?
Often, yes. Strategies include lowering the antipsychotic dose if possible, maybe switching to an atypical antipsychotic with a lower EPS risk, or adding another medication specifically to counteract the EPS, like benztropine or amantadine.
Okay, so there are options for the early onset movement issues. But then there's tardive dyskinesia. That sounds like the more persistent, worrying one.
It absolutely is. Tardive dyskinesia, or TD, is characterized by involuntary, repetitive movements, often of the face, tongue, lips, jaw, but sometimes limbs or trunk too. And the key things are that it's delayed. It usually only appears after months or years of treatment, and it's thought to result from that dopamine receptor supersensitivity we discussed.
That long-term adaptation by the brain.
Exactly. And tragically, TD can be irreversible even after stopping the offending drug, and it's notoriously difficult to treat effectively.
So prevention is key then.
Absolutely paramount. Using the lowest effective dose of the antipsychotic for the shortest necessary duration is the main strategy to minimize the risk. Vigilant monitoring for early signs is also crucial.
Is there any treatment if it does develop?
Yes. Thankfully, there are now FDA-approved treatments specifically for TD. Our source mentions zolbenazine. It works by inhibiting a protein called VMAT2, which helps package dopamine into vesicles for release. So it essentially reduces the amount of dopamine being released presynaptically.
So it tackles the problem by reducing the dopamine signal that the supersensitive receptors are overreacting to.
That's the idea, yes. Yeah. It offers hope for managing TD, although prevention is still the primary goal.
Okay. Now moving on to the atypical antipsychotics. The big selling point, as you mentioned, is generally fewer EPS compared to the typicals, right?
That's correct. It's one of their main advantages. Their different receptor binding profile, particularly the stronger serotonin 5-HT2A antagonism relative to the D2 antagonism, is thought to be responsible for this lower risk of movement side effects.
That's a huge deal for patients, I imagine. Now, the source talks about some specific atypical drugs. Let's start with clozapine. It sounds like it's kind of in a class of its own.
Clozapine is unique, yes. It's often considered highly effective, perhaps the most effective, especially for treatment-resistant schizophrenia and for negative symptoms. Its benefit is thought to come from blocking D4 dopamine receptors and those 5-HT2 serotonin receptors more strongly than D2 receptors. And it has a very low risk of causing EPS or TD.
So very effective, low movement side effects. What's the catch?
The catch is significant. Clozapine can cause quite a bit of sedation, weight gain, and those autonomic side effects like dry mouth and constipation because it also blocks histamine, muscarinic, and alpha-1 receptors quite strongly.
Okay.
But the biggest concern, the most serious risk, is a granulocytosis.
Granulocytosis, that's the dangerous drop in white blood cells.
Exactly. A severe lack of neutrophils, a key type of white blood cell, which leaves the person extremely vulnerable to life-threatening infections. It's rare, maybe affects 1% or so of patients, but because it can be fatal, it requires incredibly strict monitoring.
What kind of monitoring?
Regular blood tests to check the white blood cell count. Typically, it's weekly for the first 6 months, then maybe biweekly, then monthly if things remain stable. Patients have to be registered in a special program. It's a major commitment and limits its use to cases where other drugs haven't worked.
Yow, that's intense. Okay, what about olanzapine? How does that compare?
Olanzapine has a somewhat similar receptor profile to clozapine, and it's also quite effective, including for negative symptoms. It tends to cause fewer of those autonomic side effects than clozapine, though. And crucially, olanzapine does not carry that risk of a granulocytosis.
Ah, so similar benefits perhaps, but without that major safety concern. Still has side effects, though.
Oh, yes. Olanzapine is notably associated with significant weight gain and metabolic issues, like increased risk of diabetes and high cholesterol. So, different set of concerns.
Right. Okay, next up is risperidone.
Risperidone is another commonly used atypical. It's effective, but compared to some other atypicals like olanzapine or quetiapine, it actually has a somewhat higher risk of causing EPS, especially at higher doses. It acts a bit more like a typical antipsychotic in that regard.
Interesting. Any other points about risperidone?
It's also more likely than some other atypicals to increase those prolactin levels we discussed earlier. And there's some concern about it potentially prolonging the QT interval on an ECG, which is a measure of heart electrical activity, raising a small risk of cardiac arrhythmias.
So again, a unique profile of effects and side effects. It really seems like there's no single best atypical, just different trade-offs.
That's a very accurate way to put it. And then there's aripiprazole, which the source describes as working a bit differently again.
How so?
Aripiprazole is often called a dopamine system stabilizer because it's a partial agonist at D2 receptors and also at serotonin 5-HT1A receptors.
Partial agonist, what does that mean exactly?
It means it binds to the receptor and activates it, but only partially less strongly than the natural neurotransmitter dopamine would. So in brain areas where dopamine is too high, it acts like an antagonist, blocking the full effect. But in areas where dopamine might be too low, it provides some baseline stimulation.
Huh. So it can kind of turn the volume down or up, depending on the situation.
That's the concept, yes. It aims to stabilize dopamine activity rather than just block it everywhere. It's also an antagonist at the 5-HT2A receptors, like other atypicals. This unique mechanism is thought to contribute to its generally good tolerability profile, often with less weight gain, sedation, or metabolic issues compared to some others, though it can sometimes cause akathisia.
Fascinating. Like a smarter drug, in a way. Okay, putting this all together, what are some of the main treatment guidelines or considerations our source highlights?
Well, the source suggests that atypical antipsychotics, maybe excluding clozapine as a first option because of the monitoring, are generally preferred as the initial treatment for schizophrenia nowadays.
And the main reasons for that?
Primarily the lower risk of EPS compared to typicals, and also their potential greater effectiveness against those difficult-to-treat negative symptoms, leading to potentially better overall functioning and quality of life.
Makes sense. Aiming for broader symptom control with fewer debilitating side effects. What about how quickly people might see results?
Some improvement in positive symptoms might be noticeable within the first week or two. But as we mentioned, the full maximal therapeutic response usually takes longer, often 6 weeks or even more.
So patience is needed.
Definitely. And once someone's symptoms are well controlled, the dose is often reduced to the lowest effective level for maintenance to minimize long-term side effect risks.
How long does treatment usually continue?
The recommendation is typically to continue treatment for at least 12 months after a first episode resolves and the person is in remission. After that, a careful discussion happens about maybe continuing low-dose maintenance long-term versus attempting a very gradual withdrawal, weighing the risk of relapse against the risk of long-term side effects like TD.
And definitely no stopping abruptly.
Absolutely not. Abrupt discontinuation is strongly advised against. It can cause not only a potential rapid relapse of psychosis, but also significant physical withdrawal symptoms.
What kind of withdrawal symptoms?
Things like insomnia, vivid dreams or nightmares, restlessness, agitation, But also physical stuff like nausea, vomiting, diarrhea, excessive salivation, sweating. It needs to be tapered off slowly under medical supervision.
Got it. Well, this has been an incredibly detailed look at these medications, drawing straight from our source material. It's clear they're complex drugs with profound effects.
It really is. I mean, to kind of wrap up the key takeaways,
Mhm.
antipsychotics work mainly by modulating dopamine and serotonin pathways in the brain. They target the different facets of psychosis, the positive and negative symptoms, with, varying success and always with a profile of potential side effects.
And that big difference between typicals and atypicals really comes down to their receptor affinities and the resulting side effect burden, especially those movement disorders.
Exactly. The atypicals generally offer an advantage there,
Yep.
though they have their own issues like metabolic side effects. It really emphasizes just how intricate brain chemistry is and how intervening in one system can have ripple effects throughout.
It absolutely does. And that leaves us, and you, our listener, with something to really think about. Considering this incredible balancing act of neurotransmitters we've discussed, what does it truly reveal about the sheer complexity of the human brain? And what challenges does that complexity pose for developing treatments that are both highly effective and precisely targeted with minimal side effects?
Hmm. Or maybe, how will this ever-deepening understanding of these mechanisms continue to fuel research? Could we see even more refined approaches in the future, perhaps tailored more to individual neurochemistry?
Definitely food for thought. It reminds us that the science is always evolving, always learning more about the brain and how to best support mental health.